Hi, everybody. It's Sue Jones from RTSO, and I'd like to welcome you to our tips and tricks for intubation and extubation for COVID-19 patients. Today we have Matt Coe from Mount Sinai, and I'm going to let him say his own title because it's quite long. And we also have Kelly Hassel, the president-elect, and the clinical resource leader at St. Joe's in Hamilton. So I'm going to turn it over to Kelly. I will manage the questions, so continue to put your questions in the question box, and when we come to the time when it's appropriate to ask questions, I will read them out. Kelly, over to you.
Okay, hi everybody, and thank you for joining us. I hope that you're all keeping well and doing your best during these difficult times. And we're very fortunate today. We do have Matt Coe, who's going to share some experiences with us in terms of intubation and extubation and some of the training that they've been doing at Mount Sinai in terms of managing COVID patients. So Matt, are you there? Matt's on mute. Just give Matt a second. He's trying to unmute himself. The joys of technology. Matt? Okay.
There you go.
Sue, while we're waiting for Matt to get back on, do you just want to take a couple minutes to update what we've been doing in RTSO, and I'll make sure that I can connect with Matt off the platform to make sure he's still there.
Sure. So of late, we are still participating in the daily COVID-19 rounds from the Ministry of Health and the Emergency Operations Center, and strongly pushing forward yesterday and today some information around these apparent 10,000 ventilators that have been purchased and the consumables that are going to be going along with them, and who's going to manage the distribution. So we've been asking those questions. We'll continue to ask them, and as soon as we get information, we can provide it to the province. And then also really looking at PPE protection where you're working, if it's in hospitals or in the community. And specifically around a directive that was recently released yesterday from the ministry around PPE for nursing in the hospital, and did not include anyone else. So we've provided some feedback on that. And oh, you're looking at my email. Okay, sorry. Somebody says we're looking at somebody's email. That might be mine. Maybe, maybe not. I'm not sure. So anyway, we've been continually providing feedback to the ministry about that. And there's a collaboration table tomorrow that we also attend in the morning that I will be attending. And continue to bring these kinds of issues forward. So what I'm going to ask actually is if there are things that you're finding within your practice and there are concerns that your workplace or you feel it's a system issue, please forward it to our email office@rtso.ca, and we can bring that forward, especially if we're finding kind of common things that people are sending in. So I'm hoping that you can do that for us as well, so that we can bring that forward. And there'll be a collaboration table, like I said, tomorrow meeting, and there's usually one every Thursday for the last couple weeks. So I suspect there'll be another one next Thursday, just before Easter. And as if the predictions are correct and the numbers start to ramp up, we're seeing increasing numbers of critical care patients on ventilators right now. This morning we heard there was 97 people admitted to the ICU, I believe, and almost 3/4 of those are on ventilators. So we're starting to see that rise now, and as that rises, I know there's going to be human resource issues, there's going to be supply issues, so we need to hear from you guys. What are your biggest concerns? Okay. Kelly, you want to start now?
Yep, so I believe that you actually have Matt muted on your end.
Okay, so let me unmute him.
try again.
Yeah, hang on.
Okay, it should be good now.
Okay, try now, Matt.
Hello?
Yeah, we can hear you.
Okay, good. All right,
Okay,
can you hear
Matt.
me still?
Yeah, we can hear you. So if you want to introduce yourself a little bit and then start in on the tips and tricks.
Okay, my name is Matthew Coe. I am the clinical educator and ICU practice resource RT for respiratory therapy at Mount Sinai Hospital. I also serve on the acute resuscitation committee as the co-chair with Dr. Stephen Lipinski. Thank you for this opportunity. And again, I'll echo Kelly's remarks that I hope everyone is staying strong and not losing heart and continuing to fight the good fight. Did you get all that?
Yep.
Okay, so getting right into, I guess, tips more than tricks for intubation, extubation. Really, I'd like to preface this just by saying this is our experience with COVID patients, and by no far stretch of the imagination am I any type of expert in actually any field, including respiratory therapy. I'm just a regular RT Joe, RT working. Fortunate to work at a downtown teaching hospital. But anyway, if again, this is just going to be information sharing and sort of sharing our experience. So going right into it, I do have some comments from the, there's an email stream that was shared between our intensivists. So one of the first ones who actually intubated a COVID positive patient, I have some of his comments. His name is Chris Yarnell, and he's one of our new clinical associates at Mount Sinai Hospital. I also will be sharing just things that have come up at a lot of the mock protected code blues and simulations, and those are run through an organization called SimSinai, and that's our simulation center. Okay, so getting right into it, let me just organize my sheets here. So for the actual protected code blue intubation or a elective intubation for a COVID positive patient, really it comes down to having the fewest number of essential people in the room, and that usually dictated by the team lead, and that just prevents sort of cross-contamination errors, and again, when you're all in that sort of full PPE, it is communication becomes really difficult. So the fewest number actually of people that personnel that are required in the room is advisable. It's a good idea to have sort of a hot runner, so someone who is in full PPE. I mean, if you have the opportunity to have this take place in a negative pressure room with an anteroom, it's not a bad idea to have a hot runner who stays in the anteroom in full PPE, and then they can actually enter the room, bring in supplies if needed. The point that was brought up was to have all RSI meds drawn up ahead of time, and that goes with all post-intubation IV infusions, other medications, pumps, all the airway equipment. Just have everything ready before you actually don all the PPE. So one, you're not sitting there with mask, face shield, all that stuff, making communication difficult, but it's also, I mean, it gets quite hot. So have everything ready, and then just before you go in, it's a good idea to do a timeout, have the team lead just sort of lay out what the plan is going to be, and then everybody don your PPE. During our simulations, we found that having a PPE monitor certainly helps to make sure that everybody is putting it in the proper order. And then again, if you don't have a monitor, even just using a buddy system to make sure that you're checking each other in terms of proper donning of the PPE. Once you're inside, we found that once the patient was intubated, for confirmation of, well, actually, let me speak about the actual intubation. So all of our elective intubations for COVID positive patients or persons under investigation, or response to a protected code blue are all done by video laryngoscopy, just because it does provide you with maybe a 1 or even possible 2 Cormack scale increase in the airway visualization. So, I mean, it just increases your first pass success for intubation. And it also allows you, the person who's intubating, a fair bit of distance. We use, I mean, I don't want to plug any company, but we do use the GlideScope platform, and that it does allow the intubator to be a fair bit away, their face a fair bit away from the actual face of the patient. Some things that we observed, for ETT confirmation, I mean, again, you have direct visualization. Our anesthesia colleague said that you do need sort of 2 modes of confirmation. So we were doing direct visualization with video laryngoscopy, but we did add a calorimetric end tidal CO2 detector. Our observation was, because we are adding a filter between the inline and the end tidal, post-intubation, where we bag the patients for confirmation, the calorimetric end tidal detector does take a couple of breaths, maybe as many as 3 or 4 breaths. So again, you've seen the ETT go through under direct visualization, but just not to panic and just wait for that CO2 to get through the filter for the calorimetric change. There was discussion about clamping or versus not clamping the ETT once the patient was intubated. But again, all of our intubations would be RSI. So the patient clamped the tube to prevent oh, sorry, phone. Something that came up was the amount of garbage that ensues. We quickly overwhelmed the small garbage bin that was in the room. Again, this is all query COVID contaminated garbage. So again, it's good to have a large bin or multiple bins of garbage in the room. Something that we discovered, and again, I don't want to make this a plug for any sort of company or vendor, but we did just procure new Servo U ventilators from Yatinge. The beauty of those vents is they actually have a removable screen with an extension cable, so that you can actually leave the vent in the room but pull out the monitor and all the associated controls with it, to have it outside the room to prevent multiple entrances into the room. Another good idea was to have extensions put into the infusion pumps, which would negate the need for the nurse to actually go in to reset the pumps or reset air in line or any of those conditions. One thing that came up was just, I can't stress this enough, is to practice. And that's with respect to donning and doffing. Even though we've had multiple simulations run in sort of that high stress situation, little things get missed. And it's those little things, especially during donning and doffing, where we think the risk of transmission is quite high. So really, just the more you do it, whether you practice with a buddy, whether you run mock scenarios, simulations, however it is done, just to review your organization's policy and just to practice that donning and doffing. What we did find was, don't rush any of that. So slowly doff your mask, slowly doff the gloves, slowly doff the face shields. Really take your time to make sure there's no cross-contamination. Again, as healthcare workers, I mean, we always have a quick response time, but I mean, in this current status, really, you need to protect yourself if you want to help your patients. So please take time, don't rush into the room. I mean, with apologies to any COVID positive patients or family members of COVID positive patients, but really take your time before you go into the room to make sure and to ensure that your donning is done properly and that you're protected. Again, having that timeout before you enter by the TL just to reiterate the main points and to make sure that everyone knows exactly how this course is going to be run is super important. Another idea that came up was just a monitor for the overall process and not necessarily the actual intubation or the running of the Code Blue ACLS algorithm or whatnot, but just someone who is takes a step back and looks at the whole process itself. So what came up was we had a patient that was transferred from Emerge on a stretcher, was admitted into our negative pressure room. And then we didn't realize that the support staff, they didn't have robust training for donning and doffing. So we sort of caught them before they went in to make sure that they were donning properly. The stretcher that the patient was transported on was sort of just relegated to the hallway. There wasn't really anybody taking note that, hey, this is a contaminated stretcher, that it should be wiped down. So, I mean, in the mad rush of getting this patient stabilized and into the room and with hooked up to monitors and whatnot, initiating mechanical ventilation, there's the little things that might get missed, and it's maybe not a bad idea. I mean, this is going to depend on your resources, but it's not a bad idea just for someone, sort of the overall handler, just to ensure that cross-contamination doesn't occur. For the actual intubation process, we did have the person intubating as well as a person assisting, and that's usually going, I mean, at our site, that's going to be the anesthetist or ICU fellow or the Emerge doc, and then the RT assisting. We are recommending double gloves. So as soon as the intubation is finished, to doff the outer pair just within the room, and that just gives you an extra layer so that you can, I mean, those are going to be the most contaminated equipment that's in the room as part of your PPE, or those outer gloves immediately post intubation. So we are recommending 2 pairs of gloves, and if you have access, extended length gloves and then a shorter pair over them, you would doff the outer pair, and then you would have still a protection from for the extended pair of gloves underneath. When it comes to doffing, I mean, hand hygiene, like really religious hand hygiene, will make the difference, I think. In our steps for doffing, I mean, we do have sort of bouffant cap, face shield, mask, hand hygiene, which is an alcohol rinse, and then gown. I might even be saying this wrong. And then, hand hygiene and then gown rolled away, and then hand hygiene and exit. But I mean, if you wanted to put another hand hygiene step in with the alcohol rinse, I mean, you can't do it enough. And again, this virus, it dies and it's killed by alcohol or Virox or whatever it is that your organization uses. So, I mean, sure, it's scary because it is aerosol transmission, but I mean, close contact is where I think transmission is going to happen if it's not done properly. And so you can't do enough of that alcohol rinse for your hands. Do multiple steps if you need to be in between mask, face shield, bouffant cap, gown, booties if you're using them, but just to stress hand hygiene, like religious hand hygiene during the doffing. And again, if you can have either a buddy system or a monitor for the doffing, it just really, I can't reiterate this enough, is just to make sure that it's done slowly and it's done in the proper order. I mean, that just sort of, I'm sorry, I'm not as prepared for this webinar, but just sort of, those are our observations from doing the simulation. We are running continual simulation sessions, and we're doing them on the actual floors where the COVID patients may be cohorted. But again, the more you run, the more familiar you are, the more you're going to find sort of gaps. But also, it's just that continuous reiterating and reviewing, just so that becomes sort of second nature. But again, doing it on the floors where your staff actually worked helps. So if it's Emerge, running in Emerge. If it's on your medicine wards, running your medicine wards. If it's in ICU, running in an ICU room, just so that everyone's familiar, and that just lends itself to more realism when you run these simulations, because there always is that little element of sort of artificialness. Okay, if we can talk maybe just about the extubation. So according to our policy that we put together, the extubation again is classified as a aerosol generating medical procedure. So the recommendation was to extubate in a negative pressure room wearing PPE associated with airborne. However, we did come up with just using the bag and heliox because we did have a patient that was vented in a non-negative pressure room. So, I mean, I can just go quickly over what we did was we filled a heliox, we filled a large bag with heliox, and the only reason we did it with heliox is just so that it would stay inflated and not collapse on the patient itself or him himself. And then we all donned our PPE. The bag was placed over the patient and sort of tucked in around him. Sorry, so before that happens, you want to make sure everything is ready for the extubation. So we had a TAVR mask ready. We didn't turn on the flow, or we're recommending not turning on the flow because that may move around some of the aerosol that's captured in the bag. So we placed the TAVR mask on the patient's forehead. We're recommending maybe not turn on the flow at that point. Pre-oxygenating the patient because they will be breathing 80-20 heliox until the actual TAVR mask is applied. I mean, cuff leaks, sure, you can do that prior to it, or you can do it just prior to you extubate. Again, that's something that probably might be site specific, but just have everything ready to go, explain to the patient, and then so immerse the patient into the bag, have it go down as far as it can past the shoulders. The anchor fast, or the apparatus that holds the ETT, it was undone. We did try to save the OG, but again, if that's going to be in the way, it's going to come up anyway with it. And then we did drop the cuff underneath. We made sure that there was suction ready, and it was on. And then we actually grabbed, once the cuff was down, we DC'd mechanical ventilation, and then once the cuff was down, we actually pulled the ETT from outside by grabbing it through the bag. And then we extubated the patient, sort of tucked the bag around him, hanging onto the ETT. And with our one patient that we did extubate this way, he did cough gave up 2 large coughs, and we hope that that was captured in the bag. And then we slowly gathered the bag around him, hanging onto the ETT. And again, we're theorizing that we captured any aerosol into the bag. And then we applied the TAVR mask and turned the flow to whatever it is that we're putting. I think we're recommending 6 to 10 liters. And he tolerated quite well. But afterwards, now we were left with this large helium bag, like this big circus balloon. And then it was actually one of the ICU nurses who said, just apply the suction tubing to it. So we did take off the anchor, and then we inserted from below the bag the suction tubing and evacuated all of the heliox, as well as any aerosol and COVID particles through that. Eventually the bag collapsed on itself. We rolled it up, and then we disposed of it. And so that was sort of our experience with extubating our first COVID patient. I'm not sure if this is something that we're going to continue to do. We did do a short write-up, and again, I can provide, or Kelly or someone can post my email, and you can connect with me, and I can just send you just a rough layout of what we did. There is an instructional video, but again, it's not quite complete or robust in the way that we would want to recommend that you do this. But I think the bottom line, ultimately, if you are wearing proper PPE and it's done properly, I mean, that gives you the confidence to be able to stay in the room and to know that if there are any sort of leaks or any mishaps, I mean, you're going to be protected. Realizing that, again, this is not an airborne transmission virus. So ultimately, that gives you sort of the comfort to be able to stay in the room. And I mean, I stayed in that room with that patient for about half an hour, just making sure that he was stable and, gathering all the equipment, moving things around. And again, just you don't want fear to be directing any of your procedures. Again, because we really have to be good stewards of PPE, just in light of the amount of PPE that we're using. But again, that's what we've done. Right now in our ICU, our policy is to don N95s for any close contact with COVID positive patients. Personally, I think that is just to placate any fears and address any fears that people have. But again, really, it's a aerosol droplet contact, and that will protect you. So anyway, that was our experience with extubating our first COVID patient. I think that's all I have to say for now.
All right, thanks, Matt. Actually, there's quite a few questions. So I am going to start with the ones at the beginning as people had started to enter them in, and then you can answer as you see fit here, okay? Just wanted to let everybody know that we are recording this, so we will post a link on the website, and Kelly has been taking notes, and we can post those as well for anyone who missed it, or you might have missed something due to audio issues. So Matt, so I just want to make a comment. Carol put on, I think I put it in the chat box, 143 people in ICU right now, and 97 are vented across Ontario. So Matt, the first question, has anyone formalized stopping CPR during a glide scope intubation for suspected or positive patients? I think Alberta Health Services still continues to suggest ongoing CPR. Is there any kind of comments on that?
I don't think in any of our experience, and I can double check this, but I don't think we've actually done CPR in a protected code blue as of yet. I can double check. But again, really, if you're wearing your proper PPE, sorry, is this question about aerosol generated during CPR?
I suspect so, yes.
Not to interrupt you, but I can tell you in Hamilton, we are stopping CPR to do the intubation.
Mm-hmm.
It's in our policy.
I think we are too in Barrie.
That helps.
Okay, so this is actually just to increase first pass for the intubation, not necessarily aerosolizing COVID with the CPR, correct?
It doesn't really specify, but.
Okay. I mean, I think it just makes sense to stop because you want to get that patient intubated and ventilated, right? That's the first thing you want to do. I think it just makes sense in practice. Again, I'm an ACLS instructor, and we always say compressions first and minimize compressions. But again, given the current climate, I think it's completely reasonable to establish that artificial airway first.
In this situation, I'm an ACLS instructor too. I would say the same thing. I think you would stop compressions, allow the patient to be intubated, trying to minimize kind of aerosolization, and then continue on with CPR afterwards.
Absolutely.
Okay. So the next question, so Scarborough Health Network, where Chris Yarnell also has the physician privileges, has a protected code blue procedures with no compressions using RSI and glide scope intubation. So in that hospital, that's what they are doing. So thanks for that. That's good. This one is, I've heard of some organizations performing their CPR and intubations outside. Is that a safe recommendation if you don't have negative pressure?
Outside the room? I don't understand the question.
I'm not sure what that means, outside. Maybe outside, I'm not sure. I don't know. Maybe you can clarify that. That was from Monica. Maybe you can clarify that and I can ask that again. Okay, we're scrolling down. Okay, Scarborough Health Network's experience with Servo U and Servo I ventilators is that they don't have heated expiratory blocks, so there is often condensation in the circuits requiring a break of the heated circuit or a change of the HME. These circuit breaks are considered aerosol generating medical procedures. Absolutely they are. And you must.
If I can weigh in.
Yeah.
So we just purchased for our expanding ICU in 2022 a number of servo U's. We elected not to buy the heated expiratory, the expiratory filter heaters. But in light of what was happening, we actually retrofitted them, so they are available. And again, I don't want to be plugging any vendor or any company, but they do make them. They are available. We did get them in. We've retrofitted all our servo U's so that the heated expiratory filters, and they come with proprietary filters that need only to be changed every 48 hours. So going forward, that's what we will be employing, just to ensure that there is no rain out. We did notice that there's a fair bit of rain out because the expiratory filters aren't heated. So we did elect to retrofit them. And hopefully that just reduces the circuit breaks every 48 hours in terms of replacing the mechanical filters at the expiratory end. And we're still doing heated humidity, just because with the HMEs, I know they have to be changed regularly. I don't know if it's Q12 or Q24 plus PRN. So again, we have purchased a number of HMEs, but we're still electing to do heated humidity as long as we still have the supplies for it, just because it negates breaking the circuit more often.
Yeah, and that makes perfect sense. And so from our end, we're pushing forward with the Ministry of Health in terms of, because I've seen this happen where we have no water.
Right.
And that could become, especially for these kinds of patients, that could become a real problem. So that's good to know. A question is any neck protection for PPE required or intubation or extubation?
Oh, sorry. So we did look at that. The one thing that you are exposed, that is exposed during this, is your neck. So we did source face shields that have a little drape that comes down, and then it actually velcros together, so it becomes like a little bit of a beak, so that prevents any sort of pulling away. But again, if you don't have access to these, it's absolutely imperative to sort of wipe down your neck, because that is sort of the one area that is exposed during any of your AGMPs.
Okay, great. This is a good question, actually. Why does Public Health Ontario not recommend a bouffant cap for intubation?
So again, this is such a fluid situation, and we can only respond based on feedback. Initially, we did not include a bouffant cap with the AGMP or PCBs. The anesthesia group and the OR group actually, when they do sterile procedures, they are required to wear the bouffant cap. So if there was a COVID positive patient in the OR or in L&D where anesthesia was responding for any of this sterile procedures, they were required to wear the cap. And then we adopted it just because it gives you that extra layer of protection should there be any aerosol generated into the air itself. We did find, though, that unless you do it very slowly and very purposeful, depending on what kind of bouffant you wear, ours have a little elastic, and if you don't take your time, what can happen is the elastic snaps, and then it further possibly generates aerosol from whatever's on top of the bouffant itself. But I mean, again, you have to sort of weigh risk benefit, and looking at our doffing techniques, if you do pinch and pull very slowly, it does prevent any of sort of that springing of the elastic and snapping of the elastic, but it does provide you just that extra layer of protection, as well as for people with long hair. It does get the hair out of the way if you are assisting with intubation or doing the intubation itself.
Okay, great, thanks. The next question is, what's the process on transporting patients from emerge to the ICU once they're intubated?
So again, this is fluid. We're ensuring that, so right from the room where they're intubated, to expedite that transfer, we're making sure that there is sort of a second team that's clean in full PPE to take over. So we're requesting, we're mandating 2 RT response, multiple nurse response, MDs, so that the quote unquote dirty team inside the room can start the transfer, and the clean team outside takes over while the dirty team can then doff after. in terms of, it aligns quite well in terms of expediting transfer. That decided to just manually ventilate, ensuring that there is a filter between the ETT and the BVM. Just because using a transport ventilator, again, that's another piece of equipment, that's another disconnect. And so we elected not to use a transport vent. And then whatever policy that we have from IPAC in terms of having a dedicated elevator, having the hallway, the elevator, everything wiped down post-transfer. And that's sort of what we were looking at. I don't know if that answers the question fully.
Okay, that's helpful, thanks. When you extubate as an end of life or one-way wean, do you need a negative pressure room?
Oh, that's a good question. Again, just our policy is laid out for any extubation to be considered an AGMP. I don't know, that's a good question. That's something that maybe IPAC at each site will have to weigh in on.
Yeah, we can actually ask that tomorrow. That's a really good question for tomorrow. What gowns are being used for an enhanced PPE? So I guess there's an image on the screen and the person says this appears to be a level 1. Our site recommends a level 3 gown. Any kind of comment?
We've elected to go with a level 2 gown, which is fluid resistant. And that's just, I don't know, that was what came up from our policies to ensure that it's level 2.
Okay. Someone says, and I can relate to this because I work in a community hospital. So not all community hospitals have access to Heliox. So we just need to be diligent with our proper PPE, and I totally agree.
Absolutely.
Someone did ask if we can see a photo of the bag at extubation. So maybe you can send us that, Matt, and we can post that.
Yeah, I can send you the video of the actual extubation of our patient, who I think he's posted it on his own Twitter site, and so I think it should be okay to sort of recirculate it.
Okay, great.
But just a bag itself, if I can tell you the dimensions, it was just the largest clear bag that we had. It's 36 by 50 inches.
Okay. How long do you leave the patient in the negative pressure room after you extubate them?
So again, the first extubation for our COVID positive patient did happen in a non-negative pressure room, and that's why we elected to go with the Heliox in the bag. I mean, the literature out there is different, and depending on the number of room exchanges that occur in terms of the HVAC system, how much they're coughing. I mean, all these things get factored in. So the literature says some say an hour, some say 2 to 3 hours that the aerosol may stay suspended in the air. But again, for your negative pressure rooms, the room exchanges happen far more frequently. So it's hard to say what's appropriate. Yeah, again, donning proper PPE and donning it properly, I think that's going to protect any type of cross-contamination and transmission.
I think you can actually, so from my days as a charge therapist, I'm pretty sure you can actually find out from your hospital how many times per hour the air is circulated in a negative pressure room.
Correct.
So you might be able to figure that out and see then if you think that the particles last 2 to 3 hours, then you could actually figure that out.
Correct.
So that might be something.
They should have for each room as well, not just the negative pressure rooms.
Yeah, and that's for other rooms as well. So there's different time frames in terms of air circulation. So ORs obviously have air circulation a lot quicker than regular rooms, and they should know that information when they build the hospital, unless it's really old. Okay, next comment is the CAS is recommending taping the joints of the HME, the accordion tubing, inline suction elbow, and ETT, leaving the connection on the clean side of the HME untaped to reduce accidental disconnects during perioperative time. Our ICU RTs have been told not to do this. What are your comments?
I don't know. I mean, if whatever it takes to prevent any accidental dislodgement makes sense. again, depending on what inline you're using, whether you use that piece of corrugated tubing that comes with it, the actual factory specs, if they're all actually ISO 15 mil, 22 mil. I mean, there's so much variation. I think ultimately, though, again, I'm going to keep bringing this up. If you're wearing proper PPE, you're going to protect yourself from any accidental dislodgements and disconnects. I don't know if anyone else wants to weigh in. Really, though, a lot of the pressure fittings, I mean, at the Y for the circuit, for the corrugated tubing to the inline, really, they're pretty, I mean, unless they get wet, they're pretty strong and robust. For our proning of COVID patients, we did put that clause in to make sure that before you prone, that you are ensuring every single connection from the vent and then circuit is tightened up, just to prevent sort of that accidental disconnection.
Okay.
I'm not sure how much tape reinforces that.
Mm-hmm.
If I can, so I did see this come down through the list, and I believe the original suggestion came from Randy Wax. So I reached out to Dr. Randy Wax, and we had a message back and forth about this. The original recommendation stemmed from how to support the tube on transport. And so we had conversations back and forth about some of the risks associated with this. I think it's been expanded out maybe beyond what its original intent was. So the original intent was clear tape longitudinally along sort of help point. But you need to be mindful if you're doing this in your ICU and then you're proning a patient, there's a higher chance of extubating the patient if you're taping that, and how you're doing it. You want to be able to see if there is a disconnect. So I'd be very personally hesitant to do this in our setting, and doing what Matt's suggesting in terms of making sure all the connections are tight and that your circuit is appropriately secured, and looking at all the factors that would lead to an inadvertent disconnect versus trying to have tape cover that up.
Okay, thanks. The next question, is there risk of aerosol generation with Venturi mask or non-filtered non-rebreathers?
That's a very interesting question. So when we met as I think we had a downtown core teaching hospital sort of conference call between the ICU attendings, and then they actually tasked Tom Pereno, I think everyone knows who Tom is, just to look at that. Again, venti mask is not recommended for use because of the flow. And again, we have to understand it's not necessarily the aerosol in terms of an aerosol mask, so aerosol humidity. I mean, when you actually look at it, if the flows aren't high, I believe the risk of aerosol generation is low. So just because you're using an aerosol like a Misty Ox or whatever aerosol, aerosol humidity, reminding everyone that venti masks, again, because of the entrainment ports, even if you are on a low FiO2, they will entrain at much higher ratios. So the end flow that you get at the mask might be 25, 30, 35. So that, I mean, that's considered a high flow, and that sort of is what is correlated with aerosol generation risk. So when we looked at some of the literature, we could understand why dry oxygen via a venti mask was sort of being prohibited for use. And when Tom looked into it, again, it's more the flow that's associated with it.
Okay, thanks. Here's a really good question. How are you managing running sims without burning through valuable PPE?
Very good question. We have a money tree. No, just kidding. So again, in this current climate of COVID, we are reusing a lot of the PPE. I don't know if I should say that or not, but again, nobody looks symptomatic. And I think this is a little bit of a charged answer. But again, no one looks symptomatic. So we are reusing the face shields, the gowns. We aren't using any of the N95s or surgical masks.
Okay. Actually, this is a bit of a follow-up to a previous question. So this is someone saying since we're intubating and extubating in a negative pressure room, how long is it recommended to wait in the room before transferring the patient? We were told 21 minutes until we leave that room to allow for settlement. Do you have any idea of where this number might be coming from?
This is the time required for personnel to stay in the room before they exit, post AGMP?
Yes, that's what it looks like.
Oh, I don't know. I mean, it makes sense to have some settling. I don't know where that 21 minutes comes from.
Okay. Regarding the mask going into a COVID positive patient, regardless of wearing a surgical mask or an N95, should we not be taking that mask off after leaving the room, given the droplet contact precautions? At MSH, which I'm thinking is Markham Stouffville, we are being told to wear the N95 mask as long as possible, even after leaving the COVID positive room. Are there other hospitals doing this? Oh my God, that's not right.
So we're actually, oh my goodness. Again, we have to think about PPE stewardship. So as long as you're wearing a face shield over it, the recommendation that we're getting is now we wear surgical masks. As soon as you have to don an N95, you're gonna wear a face shield when you exit the room, because the mask should still be clean, because any aerosol should be protected by the face shield. The N95 now becomes your mask that you're wearing until you do another procedure.
Okay, that makes sense. Okay.
Mm-hmm.
What proportion of your COVID patients have been proned, and how soon, and what was the success rate like?
Again, we haven't had that many COVID positive patients that were intubated. We did have one, so we're actually coming up with our proning protocol. Again, I apologize. I mean, I work 0.2 clinically, which means I work 4 shifts clinically every 6 weeks. But I believe we did prone one patient. Again, I don't know if everybody received from Tom Pereno, the Center of Excellence for Mechanical Ventilation, that blog they put on, but there's a really good information and resource in that. I don't know if Kelly, if you have that, if you can post that, or Sue, you can post that, but it's a great resource.
It's available on the RTSO website as a link.
Okay, there's a follow-up here as well. Remember I asked the question about intubation outside? So they're setting up COVID intubation tents outside that are usually in the ambulance bay. And I'm not sure what facility this is. Anne is working at it. And that's what she's saying. So that's an interesting one. Have you had more success with APRV versus ARDSNet ventilation?
Oh, such a loaded question. I don't even know if I want to address this. Because we are a downtown teaching hospital, and because we adhere to the ARMA trial and the ARDSNet group, we do adhere to lung protective ventilation, mostly meaning ventilating with tidal volumes at 6 cc's per kilo of ideal body weight. The challenge with ventilating using APRV is that the release volumes, again, those aren't positive pressure volumes, but those release volumes tend to extend to 10, 15, 20 cc's per kilo of ideal body weight. It's such a loaded question. We have tried to ventilate in the past using APRV, but to have strict adherence to that 6 cc's. And that's just not the way that APRV was designed to work, because patients get quite hypercarbic using that method. So again, we don't use APRV at our site. I have personal feelings about it, but because I work here, I'm not going to comment.
Okay, that's fine. So, and we can, yeah, I'm hoping that might be something that we can follow up with some other sites that are seeing more ventilated COVID-19 patients, and that might be a good topic for another webinar in the next coming week or two.
Absolutely.
Yeah, here's a good comment. So this is Kevin DeYoung, and I know Kevin. So he's talking about your process with the bag and extubation. So here's his comment. We came up with a negative pressure room process. We will test further. We take a clear plastic bag, put it around your hand, and remove the ETT like you were grabbing dog poop, and pull the dirty ETT into the bag. Working through the kinks now, also thinking we could minimize the number of staff in PPE and therefore the viral load during this procedure.
Okay. What about when the patient coughs? Because invariably they'll cough when you extubate. Are you capturing the aerosol from the cough into the bag?
Yeah, that's a good question. Kevin, if you're still on. Next question. So I'll look for that in a minute. Did you discuss the need of wearing booties to cover shoes, and what conclusions did you come to and the necessity of that?
Currently we aren't wearing booties.
Well,
I think that's for something for IPAC to maybe weigh in on.
yeah, most, I'm going to say most, but I don't know if this is true. The two hospitals I work in, we leave our shoes at work. We don't take them home.
Mm.
So anyway, do you have any tips for proning a patient? How soon should you prone once intubated?
I'm going to defer this to Tom's COEMV site. That really, it's an amazing resource. I've known Tom for 15 plus years, and so I'm not plugging it site because he's a friend and colleague. But I mean, the research that comes out of St. Mike's, I mean, it's excellent. And Tom actually on that site has calculators for RIs, for recruitability, for how to do sustained inflation, to look for opening pressure. Outside of that, I mean, it's a great resource for this very thing that you're asking. They use, I mean, if you don't have an art line, you can actually use SAT to FiO2 versus a PF ratio. And I think that's covered in that as well. But really, if it's possible and you have the resources and the manpower, I think proning right now is the way to go to treat refractory hypoxemia.
Okay, so I know you have to go, Matt. We're over time anyway. What we'll do is there's still about 15 questions, but what we can do is we can work with Matt. We will create a question and answer document. We will post it on the website. So give us a couple of days, probably until Monday, I'm guessing. I'm also going to post the link to the recording by Monday as well on the RTSO website. So take a look for that come Monday. So I want to say thank you, Matt. This has been fantastic. And thank everybody for joining. The conversation is great. Really, really appreciate your support. And again, just like I've said in the past, if you can support the RTSO by becoming a member, we would totally, totally appreciate it. So anyways, thank you. We will be doing follow-up webinars as the topics emerge and as COVID-19, unfortunately, cases start to rise. So thank you so much, and we will talk again.
All right, thanks so much for the opportunity. If I can also just plug the RTSO, I pushed membership, especially with the newer, younger RTs who don't know sort of what happened back in '99 and 2000 with the double entry to practice exam. But again, I think there's just it's an unknown to them who is actually advocating at the government level for us. And again, it's the RTSO. So again, you guys are hosting this and that's great. So I don't feel bad about plugging this, but please join the RTSO. They're the ones that are at the front line advocating for us. They took up the fight when it was kind of this questionable second entry into practice exam. They took up the fight when the ultrasonographers sort of wanted to handcuff us in terms of using ultrasounds for art lines. Honestly, they're our voice, and we have to support that to make sure that that voice isn't silenced. So please, I know it's a little expensive and money's tight, but again, we're in healthcare, so our jobs are kind of secure presently. But yeah, please support the RTSO if you can. And thank you so much for this opportunity. And please
Thanks,
stay
Matt.
safe out there. Stay safe, please. On and off slowly. Take care and be safe.
Okay, thanks, everybody.
Stay safe. Take care, Matt.
Okay, thanks. Bye.
Bye.